All right. Good afternoon. I'm Dr. Duke Majan, CEO and founder of the Duke Spine Institute. And we're getting ready to start spine surgery, which we're broadcasting and streaming live. This patient we're about to operate on has herniated discs in her neck, and she's having symptoms from those discs. The worst one is C4-C5, then C5-C6, and C6-C7. So she has 3 herniated discs. She has opted for me to fix 2, which is fine. We're going to fix the worst 2, number 4-5 and 5-6. You could see on the MRI scan, the picture that's at the bottom corner of your screen, that the number 4-5 and 5-6 disc are the worst. We're going to be performing endoscopic spine surgery, and the patient did not want her traditional metal and fusion and losing movement and all the complications that happen with fusion surgery, which was offered to her elsewhere. She opted for minimally invasive endoscopic surgery with a laser where we actually repair the disc rather than remove the disc and fuse it. So we're going to get started. The first step is to position the patient properly. She's looking up at the ceiling. Can I have you hold her head, please? My anesthesiologist is going to hold her in slight extension. I'm going to use my fingers. We're going on the left side, and I'm going to palpate her spine. I'm literally pushing on her spine. It's only possible to do when you have the patient asleep. Shot. All right, you can see the needle, 2, 3, 4, 5. I'm at 4, 5. I want to be a little bit lower where I start, because otherwise it'll be kind of hard to move down there. Shot. That looks pretty good. So I'm going to go ahead and check my AP view quickly. I'm holding my hands onto her spine. Shot. I need to make sure the needle is somewhat near her center of her spine. It's perfect. Lateral view. So you can see I need to move a little bit off to her right or my left. And shot. All right, so we're going to pass through the soft tissues on our way to the spine. You can see the needle there. I am actually displacing the trachea and esophagus. Shot. Laterally. Shot. All right, let's get a quick AP. I'm about to enter the disc. I want to make sure I'm in the midline. I'm displacing the trachea and esophagus, to the medial side, and the carotid sheath and its contents laterally. Quick lateral. So I'm right on the front of the disc. I'm about to enter the disc in the middle. All right. Shot. I'm at the front. I'm going in. Huh? Shot. At this point, I need to direct my needle. Is my needle set up properly? Yeah. Shot. Something very strange about this needle. There we go. Shot. All right, we're inside the disc at this point. You guys see that on the lateral view?
Yes, we do.
Awesome. All right. Why don't you show the audience which disc we're at? Jordan is going to do a little counting. You go back to the X-ray view. Can you guys see the white arrow? Go ahead, Luis, inject.
Yes, we do.
All right, that arrow is pointing at the number 2 bone. You see how tall it is? Like a tall sorcerer's hat. Go all the way to the top. Right up there. Yeah, it's past the little clip on her ear. All right, that's number 2. No. Just inject the skin. The local. All right. So then the 3rd bone is there. And that tube you're seeing is just our suction tube. Maybe Luis can move that and take another picture. All right, so anyway, that's number 3. And then number 4 is that bone, and then number 5 is the bone below. So we are at the 4-5 disc, 4-5 disc. That's the top disc that we're going to be treating today. Everyone agree? Number 4-5. And we're going to do that one and the one below. Now let's go back. Can you show us the AP one more time without taking another picture? That's enough, Luis. That's enough. Show me the AP. Can you bring the AP back up, or is that possible or not? No problem, no problem. All right, I was going to show you on the AP view how the trachea and esophagus are displaced this way, and the carotid sheath is going that way. So at this point, we're ready to do our discogram. We've got our dye, and let's get a picture. All right, so let's give the shoulder pull just a little bit. Head in neutral, pulled towards you. Shot. I just did the discogram. Shot. You can, all right, now show them the tear right there in the back of the disc. You guys see the little black tear right there? That is the annular tear where her herniation came out. 2, 3, 4, 5. Everyone agree we're at the right level? All right, so at this point we've done our discogram. We can see the tear where the herniation came out of the back of the disc. That is an annular tear. Remember, the annulus fibrosus holds the nucleus pulposus jelly inside the disc. So when there's a tear in that annulus, what happens is it's like opening the top of a toothpaste. You're going to get the toothpaste, the jelly, squeezing out with any kind of pressure. I'm making my incision. It's a 4 millimeter incision. You guys see that? 4 millimeters. Now compare that to the last surgery we just did. What a difference, huh? I could see on the x-ray the guide wire, and I'm going to leave the guide wire and take the needle out. Shot? Now I have to keep checking as I'm doing this. So you want to keep checking the x-ray, make sure the guide wire doesn't go in further, and make sure it doesn't come out. Shot? So I'm going to keep looking at the guide wire tip. Show them the guide wire with the white arrow. You all see the guide wire tip? I don't want it going in any further than that. I don't want it coming out. So I want to make sure it stays there as I'm removing the needle. The next step, can you guys see this?
Yes, we do.
Is this dilator. It's like a skinny pencil. It's going to literally slide down this guide wire, and this is the dilator, and it's got a tapered tip, and it's going to spread the tissues and open them. It's not doing any damage inside as long as you do the surgery right. All right, you can see it on the x-ray. Show them the dilator tip there. Yep, you all see that? Arius, you see that?
Yes.
All right, good. So I'm going to advance the dilator down, go, shot, and it's going to spread the tissues as it goes down. It's not cutting anything. That's why this surgery is so safe, and it doesn't cause damage to your body, because we're not cutting anything inside. We're literally spreading. Shot? Okay, so you can see now I'm down on the spine at C4-5. I'm in the front of the disc, and I'm going to prove that to you. Let's get an AP view, front back view, and I'll show you I'm in the middle. So far we've had literally 2 drops of blood. That's it. Shot? Perfect. Now show them the middle of the spine. You can see the spinous process. There's the spinous process, and the dilator tip is exactly in the middle of the spine. So it's an absolutely perfect position. Now you can be a little bit left and a little bit right of the midline, and it's okay. There's no problem. About a centimeter left, centimeter right, because there's a ligament there, and as long as you stay on the ligament, left and right of the center, then you're not going to have any problems. Now if you go a little bit too far, you're going to get into something called the longus colli muscle, which sits in the front of the spine. And that muscle, if you get into it with the dilator, it's going to cause some bleeding. I need a lateral view, distraction. Now, a little bit of bleeding is not a problem, but if you happen to have a patient on blood thinners or, something that's causing them to have thin blood, then they could bleed a lot. That would be a problem. Shot? All right, beautiful. So it's going in. I'm going to take my guide wire out, and at this point, I'm ready to advance it by hammering it in. Shot? So I'm going to take this dilator to the back of the disc, right where the herniation starts. Shot? That's it, right there. I'm there. You can actually see the herniation. Show them the herniation there. You guys see that dark shadow right there? That's the herniation. That's what we're there to remove. Next, I want to show you the actual tubular retractor. The whole surgery is done with this tube. For those of you wondering, everything we use is FDA approved. So this whole surgery is FDA approved surgery, okay? I get that question a lot. Sean, is the surgery FDA approved? Absolutely. Let me put it to you this way. If you find yourself doing surgery on people without using FDA approved stuff, you're probably not going to be doing surgery for very long. Sean? In other words, it's a bad idea to use things the FDA hasn't approved, in my opinion. But what would I know? I'm just a spine surgeon. All right, I'm twisting as I'm going down because it helps get the tissue off the tube. Good. We're just about in front of the spine. At this point, I am going to need some distraction from Dr. Berndas, my anesthesiologist. And I'm going to need him to give me some inline traction as I advance this tube through the disc space to the back. More distraction. And we're doing counter pressure on the arms. Shot. Oscar. Are you pulling it down on the shoulders? There we go. That's better. I'm watching my tip of my dilator to make sure it doesn't go back any further. What happens if the dilator goes back further? It's bad. It will go into the spinal canal where the spinal cord is. We don't want that. I'm happy with that. Good. Are we relaxed, chemically paralyzed? We should be, because it's a bit tight. I'm just wondering if she still needs a little more muscle relaxation. Huh? Any twitches? One twitch is fine. I don't mind one twitch. Yeah, I just want to make sure she doesn't have 3 or 4 or sustained. Okay, can you all see this?
Yes.
Let me have some irrigation.
Yes, sir.
So look at that. Look at this. I'm just putting a little irrigation. But what a difference, huh? Between a PCDF, a fusion, and the DLDR. We've lost 2 drops of blood. Look at this. Can you guys see this?
Yes, we can.
4 millimeter incision. We're going to fix 2 discs with that. That's the advantage of minimally invasive surgery. Now, this is an endoscope, and you've got irrigation, light, laser, and of course the suction is here. So we're going to head in. We've been doing this endoscopic surgery now at Duke Spine Institute for 16 years. We do about 100 surgeries a year. Lately, we've done a lot more because more people are finding out about the surgery and they want it. So our numbers have gone up. I'd say we're at about 150 to 200 a year now, and climbing. People are learning about this and they don't want the traditional fusion. All right, it's a little bit blurry. I just sharpened up the image by adjusting the focus. So there's a little bit of herniation in there. I'm going to go grab that out. And then we're going to get started with the laser. Now the laser is literally the perfect tool to use for this surgery. And we're using a 0.5 millimeter, 0.5 millimeter laser fiber. That's what you're seeing up there. It's got a little red color because that's the targeting beam. So I could see where it's aiming. No, I need it here on the right. Our settings are what, 20? The blue is actually the herniated disc. There's your first piece of herniation coming out. Now I want you to notice it wasn't actually that laser energy directly bringing the herniation out, was it? So what caused that herniation to come back and out? What caused it was a pressure wave. The laser actually produces a pulse, a sonic pulse, like a sonic boom, inside the irrigation. And that sonic boom it like shakes the herniations out. If that makes any sense. So there's our first customer. And you notice there's a blue plastic around the fiber. That's just to protect the glass. The laser fiber itself is made from glass. And have you ever seen how they make these fibers? These optical glass fibers? Quite interesting. They actually take a piece of hot glass and they literally drop it off a tall tower in a room that's, the room itself is sterile and doesn't have dust, doesn't have wind. It's in a special building, multi-story building. And it's the same way they make this fiber optic cables that go across the ocean. All right. So we're just going to sit here and work on removing the herniations by going back and forth. So if you have any questions, feel free to ask me. I'm happy to try to answer them for you.
We've got a few questions. First question is from John Christian.
Hello, John.
It says, "Hi, Dr. Duke. Coming for surgery for an L4-5 on the 12th of January. My question is, when you penetrate the disc with the dilator, are you tearing the annulus or pushing aside the fibers like needle through the cloth?"
Great question. Thank you. We are not cutting the annulus. We're spreading the fibers. So you are correct. Spreading the fibers in front of the disc. Because the annulus fibrosis, as the name suggests, is a bunch of fibers. They're collagen fibers. And that's what we're spreading. We got to... All right, something happened. Our fiber... Did you turn the laser off? Is the laser off? Why did you turn it off?
But it's ready, right?
Yeah, but I'm sitting here turning it on. It's not working. And I'm wondering why. All right. So to answer your question, you're correct. It does not, we are not cutting the disc. We're passing through the annulus fibrosis by spreading the fibers. So when we're done, we come out, there's no damage at all to the disc in the front. It's just the fibers go back to their original position. Good question. Next question.
We have a question from Ali on Facebook. And they ask, in which state does the doctor perform these operations?
Duke Spine Institute is where all of these surgeries are performed. And Duke Spine Institute is located in Florida. So we're in a place called Melbourne, Florida. Melbourne, Florida is where NASA is. I mean, it's in Brevard County, the Space Coast, very close by. So all of the rocket launches and SpaceX, everything you guys see with rockets and satellites, it's all here. Here. These are all pieces of herniation, by the way, that I have to float out. Wow. Yeah, are you sure she only has one twitch? Because I feel like I'm fighting her neck muscles quite a bit.
Let me check again.
And it's making it challenging to do this.
It's got two. I can give her a little more.
Maybe we should do that.
Sure.
I've got to be able to get down here and get this done. All these little blue things you see coming out are really herniations. There's a big tear here in her disc. Great questions so far from our audience, by the way. Luis, how many of these tubes do we have?
These ones, we have 6. 6, 6. Yeah.
Cervical?
Cervical 6, yes. Lumbar, we have probably like 10.
I'm not worried about the lumbar.
Yeah, I know, we're cervical.
Any way you can give me some distraction?
Sure.
See if that helps.
We've got one comment.
Sure. Let's hear it.
Comment from Khalid asking or commenting, this procedure will accelerate remaining disc degeneration and eventually need another surgery, discectomy infusion.
Great question. So will this procedure accelerate disc degeneration and cause the patient to need more surgery or fusion? The answer is no. We've never seen that happen. As a matter of fact, we believe this procedure reduces disc degeneration because disc degeneration is an inflammatory process that comes from inflammation. Inflammation involving the back of the disc or the annulus fibrosus. Thank you. So to answer your question, no, we don't think this procedure causes disc degeneration. We believe it stops disc degeneration. So you don't need a fusion in the future. We've not had to do fusion on any of our laser patients. And we've done hundreds and hundreds of them. So this surgery seems to be protective, preventive maintenance. Kind of like getting your teeth cleaned and brushing your teeth every day and flossing, and you don't get cavities. I guess there are people who believe that brushing your teeth every day causes you to get cavities. There's a herniation. But the reality is that this procedure prevents additional degeneration, in my experience. That's a piece of herniation right there. But it is a very good question, a very fair question.
We have another question.
Feeling better for you?
I don't know yet. It's a little too soon. But I think it's okay. It's the best we can do. Yes, Arias, we'll take the other question.
We have
You can
two
give me some more
questions.
inline traction.
One from Ali asking, how much is the cost of performing these operations and do you accept insurance?
Hi, Ellie. The answer to your question, how much do these surgeries cost? They're less expensive than fusions and artificial disc surgery. So they're less expensive than traditional surgery like fusions. Probably about a half of the price of a fusion surgery or artificial disc surgery. And the second question was what, Arias?
Insurance is reimbursed for it.
Oh, what was the second question about insurances?
If you accept insurance.
Do we accept insurance? The answer is yes, we accept insurance. It doesn't mean the insurance will pay for the surgery. Insurances have a tendency to try not to pay for surgery. In general. Doesn't matter what kind of surgery it is. So the only insurance we know that will definitely not pay for this surgery today is Medicare and Medicaid. Medicare and Medicaid are two insurances that will not pay for newer surgeries. They don't pay for fusions either in many patients, and they don't pay for artificial disc.
We had another question from Khaled.
Sure.
Is the same principle applied on calcified disc removal and myelopathic PT?
Is the same principle apply for calcified disc removal and myelopathic patients? The answer is no. If there's a calcified disc and there's no soft herniation, this is not the right surgery. You're going to want to do a fusion with a drill, basically. And but for myelopathic patients, yes, we are able to do the surgery for myelopathic patients. Absolutely. I want to come back this way. For those of you who don't know what a myelopathic patient is, more in line. A myelopathic patient is one that has spinal cord dysfunction. I'm having a hard time getting the right angle here. Is there any help you can give me?
A slight turn away from you maybe would help?
Huh?
Would a slight head turn away or a slight
You can try. Let's see. Doesn't seem to make a difference. I think distraction
okay?
and maybe that's better. What did you just do there?
A lot of distraction.
Try that. What's the noise going on over there?
It's just a bladder from the irrigation pump.
My God, that's helping whatever you're doing. It's a matter of millimeters. Not even millimeters, 1 millimeter. Huh? Yeah. This really is a team surgery.
We have another question.
Sure.
Does the laser create any kind of scar tissue from Jean-Christian?
Does the laser create any kind of scar tissue? The answer is no. The laser itself does not create any scar tissue. That's a great question. Appreciate you asking it. The laser produces no scar tissue. The laser is extremely safe, used this way endoscopically. And a lot of people ask me, is it necessary to use a laser? The answer is yes. We couldn't do the surgery without the laser. Grabber?
Thank you.
Fine. Just say changing irrigation. You don't have to. Just say changing irrigation. I got enough to worry about over here. So, give me a little inline.
I'm doing it.
Huh?
I'm doing it. Yep.
Yeah. Says some unusual anatomy.
That was a big piece.
Her disc is literally forcing me to go point up at the tip when I don't want to. But the anatomy of her disc, the way it's shaped, not her disc, her bones, her end plates, is very unusual.
We have a question from the live audience.
Okay, sure.
What can you do today that you were not capable of a year ago?
What can I do today that I was not capable of a year ago? I would say, what's that?
Be patient.
Oh, well, I would say there's not much that's changed in the last year. I think it's a fair question, but the reality is that we were doing these surgeries a year ago, just as we're doing them now. I don't know. I would say we're able to do labs now here. Couldn't do that a year ago. So all the pre-op labs patients need, we can do them here. And that's another piece of herniation, by the way. Luis, help me out here. Another piece of herniation. What are we able to do now that we weren't able to do a year ago? I mean, anybody? I'm opening this up to my team.
Maybe more surgeries during the day.
Oh, yeah, we can accommodate patients better because we have a full-time anesthesiologist, Dr. Berndes. So we don't have to schedule around the anesthesiologist. Now
He lives down the street.
he lives down the street. How's the irrigation, by the way? I don't see any irrigation coming. No, I don't see any. It's very little, but.
The DPR.
Oh yeah, yeah. Sorry, my gosh, Luis just reminded me the Duke plasma rhizotomy. So it's a more permanent treatment of facet pain. Guys, I need better irrigation here.
We have another question.
Yeah, I'll take it.
Angelo
Hi,
says,
Angelo.
Hi, Doc. Great work. Is there a degree of damage that you must see in order to do the surgery? I got
Hey.
a CAT scan and it wasn't enough for them to do anything. I feel pain and pinching at times at C6, C7.
All right, Angelo. Great question. Thank you. Couldn't have asked for a better question. What you're describing, Angelo, is a very common problem. And that is that doctors don't really know what to look for to understand patients' pain. Okay, I got it better now. The nozzle was turned and it's now better, huh?
Give you the red line now.
In line, yeah.
My hands are falling asleep.
So to answer your question, we're able to now treat facet joint pain with a new type of rhizotomy that involves using a tool that we developed here at Duke Spine that gives a better result than what other doctors have been doing for years. We call it the Duke plasma rhizotomy. So that's another advance in the last year. Another piece of herniation there.
Pretty good size. Huh?
Yeah. This is the worst of the disc, so.
We went after the tough one first.
Hmm?
We went
You
after
can
the tough one first.
relax a little bit. Oh, that's a big one. I could feel it sucking the walls. Turn the light on. Look at the size of this herniation here.
Looks like it came out of the lumbar spine.
You guys see this? Arius, you see this?
Yes, we do.
Massive herniation. See that? That's like literally a centimeter. That is a big one, all right? Sometimes we get a big one. But I want you to understand something. Herniations like her herniated disc at C4-C5, it's not one herniation that happened. It's literally a series of herniations throughout a lifetime. So the first thing that happens is injury to the disc, to the annulus fibrosus. And Arius, why don't you show them the video of how do you get the annular injury and how does that herniation occur? How does that cause neck pain?
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back, and hopefully you understand now how a herniated disc occurs and how it causes neck pain. The question, this is a herniated disc, by the way, another piece of herniation. I was asked, and Ari has told me that while you were watching the video, somebody typed in a question, can you show us what a normal what a normal nucleus pulposus looks like? The answer is no, I cannot. And the reason is simple. We're not inside the disc itself. What we're looking at is the herniation. We're looking in the annular tear at the back of the disc. So we're not anywhere near normal disc, we're in the abnormal area. For me to show you a normal nucleus pulposus, I would have to be inside the normal disc, which I need to, I would have to pull the tube backwards. And maybe I can do that at the end. I don't think so, though. So normally we don't see normal nucleus pulposus. We only see the herniation because we're inside the herniation. But normal nucleus pulposus is white. It doesn't stain blue. So it will never be blue. Can you give me inline traction, please? I need you to give me some good inline traction. Let me know.
Yep.
You there?
Yep. Helping?
Yeah, it's helping for sure.
We have another question.
Sure.
This comes from Angelo once more on YouTube. And they asked, also, is there less downtime with neck and back surgeries? When I go back to the gym, when can I go back to the gym after neck surgery?
All right, Angelo, when can you go back to the gym after neck surgery? It depends on who's doing your surgery and what kind of surgery you're having done. The surgeon, depending on if it's a good surgery or a bad surgery, it could be a few weeks or it could be a few years. So if you're asking me if I do your surgery, when could you go back to the gym? Is that what you're asking?
I believe so, yes.
All right. If I did your surgery and I did a Duke laser disc repair, this particular surgery, then you could go back to the gym in 2 weeks after your surgery. However, you cannot lift heavy weights. You have to keep the heavy lifting for 1 year and only do lighter weights. Maximum 40 pounds for 1 year. If I did a fusion on you instead, then you could go back to the gym in 6 weeks and you would have to wait at least a year as well to do heavy weights. So no matter what surgery you have done, give me traction, you're looking at a year before you go back to normal lifting in the gym. So this is, I was commenting while you guys were watching the video earlier, this is honestly one of the hardest ones I've ever done. And it's not because the size of the herniation, it's because the angle of her end plates. And she's got a very thick neck compared to a lot of our patients. So that thickness of the neck is limiting my ability to manipulate the surgical tools. But that's a piece of herniation right there. I don't have to go in and grab it out. So thick, short neck and lots of muscles make it a lot harder. Plus the shape of the end plate, which is the bony shelf above or below the disc, it's called the end plate. That can also alter the direction of my tube. And in her case, that's doing that. It's literally forcing my tube away from where I want to be to do her surgery. And that's not something that she can prevent or we can prevent. That's the way she was born. I see it sometimes. We're making do, slowly removing all the herniation. Great questions from our audience so far. I'll be happy to take more. Really? Is that noise necessary?
Sarah, is a different bag or what do you think it is? Is the bag is because it's a different bag?
Distraction?
So we okay, so we are not gonna use that one anyway.
I mean, I'd save it for emergency.
Okay. Okay, I will. Gotcha.
Any more questions from our audience?
No current questions.
By the way, what I'm removing, this blue stuff, is the herniated disc. Remember we talked about how the herniated disc can get stuck inside the annular tear and get scarred in? This is what you're seeing right here. Scarred in herniated disc inside the annular tear. This is the annular tear. It's all scarred up right now. That's the stuff I'm working on. And the herniation is quite literally stuck to the annular tear. So I'm trying to laser it off. And it's a very tedious process. It takes a long time to do. But we're getting it done. I've asked my anesthesiologist to help me, and he's pulling on the neck a little bit to give me some more room. Just a little pull by the anesthesiologist can give you a few millimeters. And that can make a lot of difference in being able to do the surgery properly. So, you know, one thing a lot of people don't understand about surgery, it's really a team sport. It requires a good team of people who all do their job properly. Give me a little more distraction. Just about done. You can see I'm running across the whole back.
I got distracted.
Huh? I need the patient distracted, not you, right? All right, just about done here. Any more questions?
Yes, we have two questions. This first one comes from Cynthia East on Facebook.
Hi, Cynthia.
And they asked, I am having ACDF. I have an anterior cervical decompression and reconstructive surgery on my C5-C6 and C6-C7 in January. I am worried about my motion in the neck. Like, will I have limitations after healing?
Yes, hi, Cynthia. You will. Anybody having a fusion is going to lose movement. The fusion is happening at the joint, which is called the disc. And by doing the fusion, you are going to lose movement permanently in your neck. There's a big herniation right there. This is a far better surgery for you than the fusion. If I were you, I would avoid the fusion for several reasons. Number one, results of this surgery are going to be better than any fusion. What I mean by results is the elimination of pain, the elimination of radiculopathy, which is the pinched nerve, the elimination of myelopathy, which is the pinched spinal cord. All of those results are better with this surgery compared to, is the irrigation cold? Doesn't feel cold. Why not? What? What is she talking about?
The fridge that they use. The fridge that you use is the one inside the men's room, the men's room. So only you capable to only 3,000.
Luis,
Yes, sir.
we've never had warm irrigation in 16 years of me doing this. Why is it happening now? Yeah, you do. It's just unfucking believable. Really not happy right now. Luis,
Yes, sir.
this cannot ever happen. This is your OR to control.
Yes, sir.
It should never happen.
Yes, sir.
Have you ever seen me use room temperature irrigation?
No.
So why are we using it?
Otherwise, they don't happen anymore.
I know, but you got to go through a checklist, like kind of like a pilot does when they fly a plane. They go through everything, okay? That's your job. That's why I have you doing that. Everything, every time. You understand?
I understand.
Who goes through the checklist, the pilot or the stewardess? Why does the pilot go through it, not the stewardess?
Make sure everything they done their job.
Make sure what?
They're done their job.
Okay, but why not the stewardess?
You can trust them.
That's right. You can't trust them.
She's not flying the plane.
They're not trained to do it. You understand? The intelligence is probably not going to be there. The motivation is not there. Some human factor is missing. That's why they're a stewardess and not a pilot. Okay? That's why you run the OR, not somebody else.
Yes, sir.
I'm hired you to do that. You've got to make sure I have everything I need properly.
No problem, sir.
This is the last of the big pieces of herniation that we're dealing with here. This thing is a beast. We're going to get it, but I'm like having to break it up into little pieces. Now, one thing I get is a lot of questions about, do you do MRIs afterwards? The answer is no. Nobody does. Surgeons, spine surgeons don't routinely get MRIs after surgery. We only do that if the patient's having problems and we don't know what's causing it. Then we get an MRI. So, Jordan, will you go outside and find out what's going on? Will you have the charge nurse come talk to me, please? The head nurse, whoever that happens to be today. Who is it, Dr. Berndes?
It's Crystal. She's here. I believe
All right, when is Crystal no longer going to be?
January
Next
1st.
year, next year first.
All right. Then have Crystal come talk. Crystal, you know what kind of irrigation we use for these surgeries? Good. I agree. Cold? This is not cold. 16 years I've never had not cold irrigation. So why are we changing that without my involvement in that decision process? What's that? Crystal, we do lasers, 5 lasers a day, and we don't run out of cold irrigation. That's not what happened. What happened was somebody forgot to put the irrigation in the fridge. Okay? Sloppy work. I don't tolerate it. Needs to be fixed immediately. So who's responsible for that? Needs to have a sit down and a little talk and a come to Jesus, because I don't ever want to have this problem again. And have a talk with yourself, or maybe Dr. Byrne does, okay? All right. I need you to do inline traction, doctor. I mean, I can't have to keep telling you. You see what I'm working on, right? This is the part I need your help. Trying to get this last bit out over here. Any more questions, Arias?
Yes, we have a question from Angelo once more.
Angelo, you've asked too many questions. I'm just kidding. Put another quarter in.
They from the previous question, they asked, like, when can I go back to the gym? And now their new question is, what about for roller coasters?
I couldn't, you said it too fast.
I apologize. They asked from the previous question about going to the gym after
I
next.
heard about that, yeah.
And then what about roller coasters?
Roller coasters, I love it. Great question. You got to wait a year. 1 year. But yes, you can go back on a roller coaster. I get that question a lot, as a matter of fact. Being here in Florida, where we have lots of roller coasters. Are you giving me inline?
Yep.
So, we get that question a lot. I'm sorry? Interesting. Just about done. Literally a few minutes and we'll be done here. I can see the fibers of the PLL right there. That's the posterior longitudinal ligament. You guys see them? All right, I think we're done. Let me just see right here. Oh, the irrigation is just failing me. Are you switching it? Thanks. I don't mind the bubbles. Thanks. I'd recommend you use a freezer.
Yeah, that's what I think we're gonna do. Have one like throw in the freezer instead.
Or just
Switch up during the
under
day.
the plastic one.
That's what, yeah, no, for real. Like switch them out. The ones people go through so many in a day sometimes. So the ones that we put in midday, just throw them in the freezer.
All right.
Is it cooling off?
I can't really tell yet. Bernice, can you give me a little more in line? Try. And stop. Stop. Release. And now pull. Interesting. I just think some of it's her musculature in her neck.
I'm
Just
really torquing.
yeah, you're torquing. Hey now. I know what you mean. That's not really appropriate at work. Oh, okay. Torquing, not torquing. I understand. All right, we've gotten a lot of the herniation out. I would say probably 90%. I've done everything I can given her anatomy. So let's hope it's enough. Those are fibers of the PLL right there. And I don't really see any herniation. All right. That was honestly one of the hardest I've ever done in my entire career because of the angle of the slope of the disc space. Watch it. Okay, we're going to do a little antiseptic, which is betadine. And then I'm going to clear it out. And we're going to irrigate. Clear out the betadine, which is an iodine-based antiseptic. Iodine-based antiseptics are really good. They're the best, in my opinion, that we have today. Okay, next step is the hardest part. It's going to be moving from this disc down to the next one. Let's go ahead and bring in the fluoro.
We have a couple more questions.
Be happy to take the questions.
Beautiful.
We're going to need a shoulder pull, we're going to need a head inline traction, and we're going to need it in just a moment. Let's get our x-ray first. That looks good. Okay, I'm going to need to see the next disc down. Jordan, I need you to come in and find that disc. In the meantime, let's go ahead and take a question from the audience. Sean?
First question comes from Jean-Christian on YouTube.
That looks pretty good. I can work with that. All right, I'll take the question.
And they asked, Jean-Christian on YouTube asked, are annular tears typically horizontal or vertical?
Are annular tears typically horizontal or vertical? They are typically horizontal.
Our next question comes from Cynthia on Facebook once more. And they asked, I quit smoking about 3 weeks ago. Should I take vitamins to help make my bones stronger before and after the surgery?
Well, Cynthia, I honestly don't know. Are you the one having a fusion done, Sean? If you're having a fusion done and you're a smoker, I don't think the vitamins are going to hurt you in any way. They can only help. So I would recommend the vitamins, yes. I think that's a great idea. All right, shot. But the fact that you quit smoking is great. One thing anesthesiologists will tell you is never quit smoking a few days before your surgery, because that's only going to make it worse. Shot? All right, we're in front of the spine. I need to make sure I'm in the middle. I don't want to get off to the side as I move my dilator down the spine. Tell me when you're going to take it. Go. All right, perfect center. Let's go back to a lateral. So I'm in the middle of the spine, and I'm going to move down to the next disc. Whoa, whoa, whoa. Don't pull asymmetrically. Hold on. You're going to have to pull symmetrically, if anything. Shot? All right, good. So I need to see a little further south, guys. Luis, put that down and give me a good pull. I need inline traction, doctor. Otherwise, you're just going to pull the whole head south. Shot? That's better. Yeah, good. Shot? 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 That feels good. AP, relax a little bit, just a little bit. AP. Let's see where we are. Give me a count. Perfect. Oh my gosh, thank God. All right. You believe in a higher power? I do. I get way too much luck not to be a higher power. Shot. Perfect. I'm right where I need to be. So give me my mallet. 2, 3, 4. Everyone agree 5, 6? Everyone?
Yes, sir.
Yes.
Disco, disco.
Disco. Relax. Okay. So we're just about to finish the second, we'd start the second disc. We've lost probably 10 drops of blood the whole surgery. There's a lot of water on the floor. We need a towel or a blanket or something. And you can see the Duke laser disc repair is a relatively short bloodless surgery. Okay.
You got it?
Hold on, hold on, hold on. Is she moving? I mean, we don't need our patients this light. All right, we'll take another question if there is. There's still water here. Okay, you didn't get any of the water by my feet. That's the most important place. Why would you not get the water by the feet? Leave it, please.
No current question.
Let me know when you're ready, Dr. Berndes. That's good.
Crystal, could you come adjust the IV a little bit for me?
Yes, I can.
Thank you. I got it going. I just had a airlock.
Give me a shot. That's it?
Yes, sir.
Shot. No, hold on. I don't want to drag that in. All right, that's good. Let me advance. You don't need to pull right now. Just have that ready. I think I'm on the spine. Let's get a shot. Looks good. I'll do that. You just get on the shoulders. On the shoulders. Let's see. Perfect. Are you giving me inline?
Yes, I am.
Shot. Nice. Shot. Nice. Shot. Nice. I think that's really good right there. All right. Let's go ahead and relax, everybody. Let's get the fluoro out. So, this patient has lots of things wrong with the spine, including spondylosis, a little bit of scoliosis, osteophytes in the front of the spine that are pretty big. But we don't treat osteophytes in the front of the spine. They don't cause any problems. So there's no reason to treat something that doesn't cause medical problems for a patient. Our focus is the herniation. Why did this switch, or did it switch? Maybe it didn't switch.
You don't want it there?
I actually, you originally had it on the other side?
Yeah.
So I'm going to move it to the other side. Thank you. Yep. Here we go.
Lights off, please.
All right, let's try this round 2. Let's go ahead and show the video how the Duke laser disc repair actually works. The educational video. Animation.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. a Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. We're here diligently working. There's another herniation at C5-C6 right there. Whatever happened to Arias? Is he still there?
Ari's still here. Henry's just making his final contributions before he leaves.
Oh, Henry, we are going to miss you terribly.
So we
Just-
have
Uh-huh.
Henry's.
No, I'll miss you guys as well.
Henry says he's gonna miss you guys a lot.
Do we believe Henry?
Yes, believe me, please.
Does he sound sincere?
He sounds very sincere.
All right. Well, Henry, we believe you.
We have another question from Jean-Christian Sarrazin-Larzio.
Jean-Christian, thank you.
Jean-Christian asks, I assume that the healthy, or his question is whether or not the healthy nucleus pulposus is affected when you go through it with the dilator.
Is the healthy nucleus pulposus affected when we go through it with the dilator? The answer is no. The nucleus pulposus is just a watery hydraulic jelly, and it's biologically pretty much inert. There's no pain fibers in it. There's no blood vessels in it. It's literally the residual notochord from embryological development just sitting in the middle of a disc. It cannot be hurt by putting the endoscope through it. There is really no structure to it. It is just a thick type of a jelly that acts as a cushion, and it cannot be harmed by putting the dilator through it. What harms it is when surgeons do an ACDF or an artificial disc and they remove that jelly out of the disc completely. And then they have no structural support between the vertebral bodies, and they're forced to put something in between the vertebral bodies like a cage or an artificial disc.
We have another question from Jean-Christian.
All right, John.
What part of the surgery makes it important to not do heavy lifting until a year out?
Great question, John. What part of the surgery makes it very critical that you don't do heavy lifting until a year out? So, Jean, what we're doing here is we're cleaning out the herniation and we're debriding the tear. Remember the tear you just saw in the video? So if you go back and watch the end of that animation, you can see the back of the disc is healing. What's actually healing is the annulus fibrosus. The annulus is the wall around the disc. That takes a year to fully heal. So until that's completely healed, you don't want to lift anything heavy because you could push out yet another piece or fragment of nuclear material, and you would basically call it a reherniation. That's what it's called, a reherniation. So you want to avoid reherniating your disc in the first year. That's why you have a lifting restriction and no contact sports for the first year. Okay? If you reherniate, you'll just be back for a second surgery. Now that said, the historical reherniation rate for Duke laser disc repair, this surgery is 1%. 1 in 100 patients will reherniate. But, you know, lately we haven't had any reherniations because the patients have been pretty good about following my instructions. And as long as the patients listen to you, the doctor, and you follow the restrictions, they generally won't have a problem. I don't know. Is the irrigation coming through normally? Huh? You're not seeing any issues over there? Can you get that out of my way? Because it's not strong here. Oh, I see why. Never mind. We're good. I need it to be on. I had adjusted the valve. What's happening is the patient's chest is in the way, so to speak, and it's interacting with my endoscope and shutting off valves. I just feel like we just don't have the pressure we normally do, guys. Is there any way to get just a little bit more? Look at it.
More pressure, please.
Okay.
Thank you. Yeah.
I don't understand. What's the holdup over there? Is it the bag is empty? Is it the machine is not putting pressure? I'm sorry?
Is it better now? One's not pressurizing very well, or it is, but it's going very, very, very slowly.
It's better.
Okay.
We have another question.
Sure.
This comes from Jean Christian, and they asked, therapists typically say that the area with the annular tear will never heal completely, that the area will always remain weaker. Is this true with this surgery?
Good question. So physical therapists say that the annular tear will never completely heal. That is true. The annular tear never completely heals when you have a herniation. The only surgery in the world where that's not true is the surgery you're watching, because this surgery cleans the annular tear, and we call it a debridement when you clean something surgically. It's a debridement. It debrides the annular tear and it allows the tear to heal naturally. So your statement is true except for the Duke laser disc repair.
We have another question.
Is it from Jean-Pierre?
This comes from Teak on YouTube.
Hi, Teak.
And they asked, Doctor, are any of your kids following your footsteps?
Are any of my kids following my footsteps? I hope they do. I don't know if they will. It would be my ultimate dream if they did, but that's going to be up to them to decide. I ended up following my dad's footsteps into medicine, and I'm glad I did. So, I don't know. I sure hope they do. Great question. All right, we are just slowly working our way across the back of this disc, and I am slowly freeing up little pieces of herniation, little bits at a time. As I said earlier, this has been a tough one because of the shape of this end plate right here, how it's sloping. But we were able to successfully treat the last disc, and this one is coming along. It's just slow. You can see, yeah, 10 minutes left. Dr. Berndes is asking me how much longer we've got, and I think 10 minutes is accurate. 15 maybe. You know, there is a lot of herniation here and a lot of scar tissue. This is all herniation. You see how it turns golden when I zap it with the laser? That's because it's calcified. It's got calcium in it. Not good calcium. Somebody was asking about a calcified disc earlier. This is a little bit of calcification in the disc. You keep an eye on that.
Knitting. She wants to go back to knitting.
There's no reason she can't go back to knitting. Luis,
Is there?
I'm just having a hard time.
What do you think?
Huh? Not traction. It's almost the irrigation issue again. That's a piece of herniation that came out. You see that? Sitting there against the bottom of the scope.
With increasing the light source a little bit, it's only at 60.
Light source, it's... The problem is if you go too much on the light, then it reflects off of the blood and the water, and it actually obscures the view. The next...
60?
Huh?
That's where you normally are, 60, right?
60%? I don't remember. Honestly, don't know. On the light source. Can you give me some distraction?
Sure.
That crack there, by the way, is the back of the vertebral bodies, the back of the disc. And this is a bone spur right here that I'm removing with the laser. That right there. You see that? And just beyond it is some herniation. So we call that a disc osteophyte complex. People say, "Oh, you can't remove bone screws with a laser." Well, you just watched it happen. Now, is the patient going to be sore after surgery? Yes. Even this surgery, they hurt because after all, we are doing some work back here, so they're going to feel some muscle spasms for a night. And then by tomorrow, they'll be gone, usually within a day. Any other questions from our audience?
No current questions.
You can see this herniation is stuck down here, and it's scarred. And I'm literally blasting all the scar tissue with a laser. I'm going to get a little closer look. I'm going to reel in the laser, bring it back a little bit, just like that. And then I'm going to lock it into place. And I'm going to get in a little bit deeper with my scope to get a little better look at what's going on. Just going to go back the other way for just a moment. Give me a little traction. Watch my fingers in the laser fiber. Luis.
Yeah, I see that.
Everything all right? Is that Crystal? How is my last patient? I can't hear you.
He was sitting on the edge of the bed when I went out there. I think he was in pain, but he looked okay.
All right, good. This is all damaged disc right here. None of this is normal. And that's the foramen. There's a piece of herniation in the foramen right there coming out. But that's a very old herniation. That's why it's not blue. Ugh. What is sticking so hard? Grabber. God damn it. The last case.
Is here.
I know he's here. Been here for a while. Remind me what we're doing.
DDR, 3 points.
DPR?
3 levels. Yeah, 3
Oh,
levels.
so it's not a laser.
No.
This is the foramen right here. You guys see this? It's a neural foramen. It's where the nerve root lives. You see that herniation right there? Super difficult because of her anatomy is really restricting me, keeping me from being able to go where I want to be. Her anatomy specifically being her collarbone and her chest.
Can you move the light source towards me? Can that be moved, the light source?
No.
Light source, you see where the light, can it be moved towards me?
Towards you? No, no, no.
Oh,
It's, yeah.
I don't think it
Yeah.
rotate it.
No.
He's talking about where it attaches to the scope.
Yeah.
No. It has to attack, I see.
Just traction, if you can give me a little bit of traction. All right. Look at that. We have about 5 minutes. I don't really see any more herniation back here. There's something right there. Now that's how it's supposed to float out with proper pressure. Flip it. This is looking better. Definitely better. Removing osteophytes, aka bone spurs.
Thank you.
And I put a lot on the tube today, Luis. A lot of pressure on the tube,
That's fine.
too.
We can fix it.
Huh?
That's fine. We can fix it.
I know, but it's got to compromise the structural integrity. You know what I mean? We need to find more.
Yes, sir. I agree.
I need you to find more.
Yes, sir.
Have you had any luck?
I have one of the reps working for me, calling Germany and everything.
Well, Germany is not going to help us.
Well, I was thinking, like, that's where all these scopes were done.
I know.
before. So maybe they have, I don't know, next to a Walmart down there.
A Walmart, a scope Walmart? I love it. Yeah. Why is it the Germans do such good work? Nobody else is able to? Just 3 minutes. I'm really pushing hard. This is like really challenging. Like a really challenging circuit, you know, Formula One circuit. Arias,
Yes.
most physically challenging Formula One circuit you've ever driven on.
It's between Red Bull Ring and
Zandvoort?
Zandvoort's quite difficult, but it's low-grade traction, so it's not super.
How about Yeref?
Probably Yareth because of the heat.
Well, that's what I feel like. I'm constantly struggling here, trying to get in, put my laser in exactly the right spot to do the surgery. And it's really hard because you got these bone spurs displacing the laser fiber. This is the PLL. This is all scarred up herniation because chronic inflammation just going on for years and years and years. And that causes the neck pain. It even causes the arm symptoms a lot of times. And that's what we're dealing with here. I've gotten out as much of that herniation as humanly possible, endoscopically. So I'm happy. Hopefully she'll be happy. And of note, I just don't see how I could have done that last disc. So flip it real quick. Let's see if I can get this last piece over here. Any questions for me?
No current questions, but we do have a comment from Teak on YouTube, and they said, Doc, difficult cases today. You are doing great. Hang in there.
Hey, Teak, thank you so much. You're the best. I love the support. You know, I gotta say, it used to be my patients that kept me going all the time. And now it's my viewers and my patients. So thank you. And my staff, of course. So our last case of the day will be a plasma rhizotomy. Again, we're not ready to start broadcasting those yet, so we're gonna just, this will be the last one you guys get to see.
I think we have 5 minutes.
Less than 5 minutes. I'm literally doing this right here, unless this opens up into something bigger. But you see how there's an osteophyte right here? I'm literally drilling through the osteophyte and then dealing with the herniation, and it's mostly scar tissue below there. It's not so much herniation, it's scar from herniation. Years of inflammation. There's a little bit of herniation right there. What an incredible surgery though. To be able to go in and fix these discs without actually having to fuse people, without having to put metal in their neck. It's pretty remarkable. This is definitely the future of spine surgery, in my opinion. It's just, it's not going to be easy getting doctors to do this surgery because they're not being taught how to do it in their training, in their residency. So it's a technique that requires training after your residency. And most doctors don't want to invest the time and effort to do that. They want to go out and make money, do those fusions, which pay well. And unfortunately, the patient is the one who suffers from that. So
Thank you.
someday I think this will be taught all over the world, this technique, and people will have better results as a result of that progress. All right, I got one last piece of herniation right here I'm doing battle with. Let's see if I can grab it out. How come I have very little irrigation? I think I might have gotten it. Anyway, yeah, it's gone. All right, good, we're done. Yeah, but we have no irrigation.
All right. Lights on, please. Thank you.
Luis, you got to get
Yes, sir.
control of the situation.
Scope off, please. Thank you.
Going forward, I mean, this is unacceptable. The whole reason of, you know, having support in the OR is to manage these issues.
Yes, sir.
All right. just about finished here. I'm going to take this tube out, and you guys are going to be able to see that we did the whole surgery through a tiny little incision. It's called 4mm incision. We lost probably 2 mils of blood at most. Hold this or deal with it. Overall, we got everything done I had wanted to get done. I think she's going to do well. She has one more herniation we didn't treat, and honestly, I don't know that we even could treat it endoscopically because the shoulders and the shortness of the neck. Huh? But the 2 discs that she wanted treated, we got done, and I think she's going to benefit tremendously from that. All right. Can you guys see this little cut right here?
Yes, we do.
The whole surgery was done through that. Now compare that to the PCDF that we did before. Yeah, here. Take it off. So there's an inch, right? That's an inch from there to there. There's this incision is 4 millimeters, less than half a centimeter. Great job, everyone. Thank you for your help. Great job, Henry and Arias, broadcasting. And I'll be happy to answer your questions. Let's show the audience the alternative surgery that we would do at Duke Spine, which is an ACDF. And they can compare the DLDR to an ACDF and see the difference.
Duke Laser Disc Repair, a comparison with traditional spinal fusion surgery. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Duke Laser Disc Repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Duke Laser Disc Repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Duke Laser Disc Repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Duke Laser Disc Repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Duke Laser Disc Repair surgery will occur inside this narrow tube. To access the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Duke Laser Disc Repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. The fiber optic laser used in the Duke Laser Disc Repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Duke Laser Disc Repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Duke laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large screws that anchor the fusion hardware. The Duke laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. The Duke laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Duke laser disc repair's half-inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Duke laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Duke laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Duke laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Duke laser disc repair, there is no damage to the muscles. The Duke laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Duke laser disc repair. Spinal fusions have a high risk for infection. The Duke laser disc repair has a very low risk for infection. In the 7 years the Duke laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Duke laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Duke laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Duke laser disc repair. In fact, most Duke laser disc repair patients experience improved mobility after the surgery. The Duke laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Duke Spine Institute. With the highest published success rate of 95%, the Duke laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
It is February 23rd, 2022, and I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much, much better. 26 years ago, I had a fusion of C6 and 7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March, and I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did
he did a
of
lot of research, and we found Dr. Duke to be a man of integrity. He films all of his surgeries. He puts many of them online, and you can see for yourself all the good work that he's doing, and that he really, really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
before
correct.
surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the way
Yeah,
up.
just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, two of them, C4-5, C5-6, and the herniations were literally sitting on the nerve. And we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny, and here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees, and
nice.
then they woke up to about 11 degrees.
Ah, so the cold front came in. We get those from time to time, and it gets cold around 60 degrees. Well, most of the time it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Duke will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So go for it.
I said that it was so important that I said I'd pay for it. You know, because we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you
yeah.
pass away.
All right, folks. We'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake. This is Dr. Duke Major. I'm here with one of my patients who underwent the Duke laser disc repair on his neck just yesterday. How you feeling?
I'm feeling better, a lot better. Already, after years of chronic neck pain, I'm already feeling better within 24 hours.
So is the pain that you had when you came here, do you still have that pain?
Not that pain, it's just, I think, a little bit from the surgery itself, but it seems like a lot of the numbness and the tingling in my hands went away, and already starting to feel a lot better.
Now you had a fusion done before, not by me, and you can see the scar there. And then you had the laser surgery done yesterday. And how would you compare the two experiences?
Night and day. I actually, when I had the fusion, had to go back to the hospital with complications. And it just took a long time to recover from that. So this was much, much better.
Now, your fusion on your neck was done by a pretty famous neurosurgeon, right?
Correct.
Even with him doing it, there were still issues.
Yes.
What kind of problems did you have with the fusion?
Well, I went there for the numbness in the hand and still the chronic pain that I've had for many, many years. And it seemed to take away the numbness in my hand, but the pain was still there. So I spent many, many years going to chiropractors. I've had injections, I've had massage therapy, physical therapy, and it, most of them gave a little bit of relief.
Did any of them get rid of your pain?
Not completely, no. Just kind of made it bearable.
And is your pain gone now?
It's certainly getting there. I'm thinking probably within a week it'll all be gone.
And your surgery was done, even though you had a metal plate in your neck from your prior fusion, we were able to work around the plate and get in there and fix those discs, especially the C3-4, which was, you can see a lot of herniated disc material in there that was causing most of your symptoms. So I'm happy you're doing so well. And you had it outpatient, so you didn't even have to go to the hospital.
Correct. Yeah. Left in about an hour, hour and a half.
What are you going to do now that we fixed your neck?
Well, I'm going to take care of it for the prescribed 6 weeks, and then hopefully I can start getting back to a normal life, be able to get back to golf and things I like to do. Dr. Duke and his processes here and everything's amazing. If you have a lot of chronic neck pain or back pain, I would highly suggest coming to him.
Awesome. All right, my friend. Congratulations.
I think the laser is the best thing out there to help with this type of surgery. It's all legit. That's all I can say about it.
Dr. Duke Machen here at the Duke Spine Institute. I'm with one of my patients who's traveled to us from Mississippi. And he came here for the Duke laser disc repair to be done for a herniated disc on his neck. And he's now here today, just one day after surgery. How are you feeling today?
Feeling great. Feel like the weight of the world has been lifted off my shoulders. Feels a lot less pain in my shoulder, no more tingling. Feels like my body's trying to recover back to normal. I think the surgery went very well. No problem whatsoever.
And you're just one day after surgery. Can you tell whether the neck pain is gone yet?
The neck pain is gone, and the pain throughout my shoulder, the tingling, everything is gone. A little soreness in my throat. My voice is a little harsh, but other than that, I feel great.
Awesome. Can you show us your incision? Oh wow, look at that. So you have a 4mm incision. You can see that right here on the surgical footage of the endoscope. We actually, when you watch the video, you can see all the herniated discs back there. We were pulling them out one at a time. You had about 20 pieces. And then you can see the nerve root right there in the foramen. And there's no herniated discs anymore on the nerve root. We got them all out of there. I had to open up the posterior longitudinal ligament and get all those fragments of disc herniation out of the epidural space that were pushing on your nerve. And I got a good look at everything and it looked fantastic. So I think you're gonna do great. Did you consider having like a fusion surgery? Did anyone offer you fusion before?
Yes, I was offered fusion. I was told that was the only surgery that could be done. I started Googling. I come across the laser surgery and I decided to give it a try. And I don't regret it. I think it was the best decision I ever made for my age, and I think the outcome would be a lot more better in the future. And it was a great experience. It really was.
And you work with metal as your job, so you didn't want metal in your neck, on your spine.
No, I think the cold weather would have had an effect on it. I think it would have caused a adjacent effect, is what they call it. When you do the fusion, it make the disc below it or above it wear out. And I'm 34 years old, and if I live another 30 years, I just feel like it would cause significant problems. I think the laser is the best thing out there to have with this type of surgery. It's all legit. That's all I can say about it.
Three, 2, 1. Okay, welcome to our live stream of spine surgery. We're just wrapping up a cervical surgery, which is the front of the spine and the neck. And you know, earlier today, our first surgery was a gentleman who needed a posterior cervical fusion and reconstruction. We did that, and you saw how big the incision was. And then now we are doing a surgery where we just went in through a tiny incision in the front of the neck. Everything went well. I was a struggle for several reasons. Anatomically, her neck is very short, which means her shoulders are high. She has broad shoulders. She had a high collarbone. These are just things people are kind of born with. And then when I went into the disc, you know, you think of the end plate, which is the surface of the bone at one side of the disc, and then the surface of the bone on the other. We call these end plates. They're basically bone, and my tube is sliding in between those two bones, and the bones were shifted in her. The way she was, I guess just the way she was born, they were kind of angled like this. And so my tube was pointing up when I really wanted to point a little more down. So I kept having my team like manipulate her position of her head to try to open up that space a little more for me to see it better and gain access to the herniation. But we were able to get probably, if I had to guess, 80% of the herniation out. And in my experience, you need to get around 50% of the herniation out to get rid of the symptoms for the patient. So I feel like she's going to be happy with those two discs. Now, she has a third disc that someday will need surgery, and she didn't want to have it done this time, and that's fine. I don't think I can get it endoscopically because of her anatomy, the way her collarbone and shoulders are so high. When you do the x-ray, you cannot see the bottom disc, the third disc that we're not fixing today, but that I would fix in the future. So I hope that that disc stays relatively asymptomatic for her, as I believed it was the top two discs that caused at least 75% of her symptoms. That's based on my best guess. And now, to be quite honest with you, when you find out that one of the discs that's herniated is actually buried down into the thickness of the tissues and bones, it actually turns out those discs are not so symptomatic. They may be herniated, but they don't usually cause symptoms because they're sort of stabilized by all that tissue. At least that's been my experience. That said, let's hope that she has a great result. We'll see how she's doing. Do we have any questions?
No current questions.
No current questions, but we've got somebody making comments in our live stream that are inappropriate comments. And we would appreciate it if you would go away and bother somebody else.
I already blocked them.
Yeah, we blocked you, so, but they could come back. Yeah. That said, I hope you all enjoyed the live stream and you've learned something. And we'll be back on Thursday with some more surgeries. Four surgeries.
Wants to know what your favorite color is.
You want to know what my favorite color is? Well, that's a tough one. It's actually kind of a blue, and if I had to pick one color that was my favorite color right now, it would be volcano blue. Volcano blue. And it's on a special car. What is it, an LT65?
Yeah.
An LT65 with volcano blue. Actually a P1. P1 with volcano blue.
Yeah.
All right. Some of you know what that is. A P1 is a McLaren P1 with volcano blue. Whew. That has got to be the most beautiful car in the world. All right. Any other questions from the audience?
No current questions.
Have a wonderful day. We're not going to broadcast the last surgery because it's a Duke plasma rhizotomy for facet pain.